Well, hello and a warm welcome to this Scotland-Malawi Partnership Health Forum and COVID-19 coordination meeting. This is the 14th meeting that we've held to help build up a multifaceted and accurate COVID-19 picture and to coordinate learning between our two nations. We're working closely with our sister organisation, the Malawi-Scotland Partnership, and with many individuals and institutions. We're delighted to have you join us today from different parts of Scotland and Malawi and elsewhere. Everybody is equally welcome and encouraged to participate. This meeting is being recorded and the recording will be shared afterwards on YouTube and so publicly available. We take your continued participation as your consent to feature in that recording. I'm Stuart Brown, the Deputy CEO of the Scotland-Malawi Partnership, and will be facilitating our 90 minutes or so together today. We'd encourage you please to use the chat function in a number of ways. To introduce yourself, no pressure to do so, but an open invitation. To add links to any resources relevant to the discussion and to ask questions. Please feel free to start using the chat function anytime you like from now to post questions. We've programmed time in our agenda for Q&A, which we know that many people value really most out of the sessions. You can put chat in, as I say, anytime from now, and we hope that our speakers will cover as much ground as possible in answering these questions. If you use social media, you're welcome to tweet or post during the meeting with the hashtag @Scotland-Malawi Partnership. We've also at Scott Malawi Youth for youth engagement. Please remain on mute until invited to speak, just for audibility on the line, and unmute yourself to speak. Your decision entirely whether you'd like to keep your video on or not, whether you find it affects your bandwidth. We'll send all participants a copy of the chat log from today, which messages are addressed to everybody. If you do have any direct conversation with individuals, please do remember to record that yourself, as we don't record them. My colleague Craig, who's hosting all of the Zoom tech today, has put a link, or will put a link in the chat box for the agenda. We'll start in the health forum for around half an hour, turning to COVID-19 at around 3:30 p.m. Malawi time, 2:30 p.m. UK time. So to our health forum. The Blantyre project between the University of Glasgow and the College of Medicine in Malawi has shared expertise between the two institutions and created a state-of-the-art research facility at the College of Medicine. To tell us more, we're joined by two great friends of the Scotland-Malawi relationship and indeed the SNP, Professor Paul Garside and Professor Mapatso Mapando. Professor Mapando, great to have you join us again. Thanks. Over to you.
I hope, thank you everybody. I wanted to just take you through what we have done. And in a special way, I'm also thankful that our Secretary for Health, Dr. Mwansambo, is here, and other colleagues from University of Glasgow, and also colleagues from Scotland and Malawi. What I have is just to learn you through what we have done together with University of Glasgow. As you can see from the first, I'm hoping you're able to see what I'm sharing. Okay, thank you. So this is just to show you where we came from. We had like a smaller, a class that we were using, and just showing you the transformation that has taken place from on the left, what we used to have as a class to what we have here now as a lab. The other point to see is that I'm showing that I belong to Kamuzu University of Health Sciences. The College of Medicine, until the 4th of May this year, used to be part of University of Malawi, but government took a decision that it should be delinked from the University of Malawi and merged with the Kamuzu College of Nursing to become Kamuzu University of Health Sciences. And just this week, our council, who are the board of governors, have been appointed, and we have a full governance structure for the new university. As indicated, it's a collaboration between University of Glasgow and ourselves. Those that are interested, you can check on their website that I've clicked. It tells you of the story. And why we have this lab is we want to allow researchers both from Malawi and Scotland and even beyond to compare different causes of poor health and life expectancy. And why the name? Because it's based in Blantyre, Malawi, but we realize some of the conditions that we have in Malawi are also applicable in Scotland, especially Blantyre and Glasgow itself, and hence the name Blantyre to Blantyre. For whatever reason, my share is not moving. Okay. So the first fact about our lab is that we would want it to be a one-stop laboratory facility, basically with three things that we want to do in this lab. We want to make sure that we are able to do research of relevance to Malawi, but internationally, but also provide a space where there is a postgraduate training. Until now, we don't have labs like that. But also as a sustainable way, we would also be providing services, diagnostic services and others, which will help us to generate income for the university. We were privileged to be funded with £1 million from the Scottish government and matched with funding in which we have used for equipment buying from World Bank and the Wellcome Trust in trainings. And whilst ourselves, we've provided space, people and other courses that are recruited, working with the lab. What we have done so far, we have recruited key personnel, trained them, lab managers, and also those that are able to market it. We have trained people in terms of how to use the equipment. We have refurbished the lab space itself, and we are in the process of buying equipment. And from the first word, we have said that we'll be buying equipment that is state-of-the-art so that it's comparable to what you get in the West. We have also just recently installed solar energy, which is powering this particular lab as an exemplar, because we want to show that we can also have a footprint in terms of usage of sustainable energy. And we have just started using it for research studies that we would show you. In terms of governance, because we want to transfer knowledge both from Glasgow to Malawi and also from Malawi the other way around, we learn it together with our colleagues from University of Glasgow, Paul, who's here, Paul Garside and Andy Waters. And I have also my colleagues from Malawi that we work together, and we have meetings every month to discuss what is happening. This is just to show you the transformation that has taken place. The benches and the flooring, everything had to be imported. We didn't have it here. We had to import it from South Africa because we want it to be an accredited lab, international accredited. And why? Because we want that even researchers, international researchers, they can find comfort and be confident that they can use this internationally accredited research facility. And this is just to show you the other way, how it's looking now. And some separated areas where we have to do specific types of tests and the entrance for what we have. So the highlights are that it's a public research facility. From day one, we said it would be internationally accredited. It's open to members of staff in KUHES, which is a new university, but also international researchers. But the difference is that the model we've taken is that we will be charging, because that's the way we are going to sustain this using our business plan that we have developed. And as indicated already, we are using clean energy. All the power, we are using solar power to empower this. And what we have seen is that the excess power that we are generating from the solar, we are feeding it into the university-wide. And as a way, the university is saving some money. Already, this facility has been chosen or was chosen as an exemplar of best practice between African and European institutions by the European Commission Directorate General for Research and Innovation. So we are happy that already we are making slides in what we are doing. And we have already acquired instruments through this grant and other grants already, and these are being used already. Of interest is also the storage space that we have created, and this has also been already started being used by other researchers on the ground. And as indicated, we are able to power it through solar power, about 30 kilowatts. And this is just to show you what we have done. The lab itself, it's based where I'm hoping you can see the cursor, but working together with a graduate from University of Glasgow based in Botswana and University of Glasgow, we put a grant and we're able to put this solar facility, which is functional now. As they were installing this, our colleagues from Botswana, we were able to train 12 Malawians in how to use this type of installation. And one of them, a lady, was employed to be the manager in Malawi. So we are happy about that. And this is just to show you some of the monitoring, because we are able to monitor even from outside the power that we are generating. And the studies that are either underway or starting, I'll start with number 2. We are looking at people that they have diabetes or hypertension, and we want to see their lipid profile. That work is already being done in this particular lab, and the preliminary results are already showing us some results that we'll share with the Ministry of Health that have got an impact on how we can help in terms of integrated services of HIV and diabetes and hypertension. At this stage also, we are about to use it for COVID studies. We have put in for ethical review, a study where we want to follow the effectiveness of the vaccine that Malawi will be using. And we are trying that once we have been given the ethical approval, we will try to check in Chikwawa, Blantyre, and Lilongwe to see how people that have got different diseases like malaria, hypertension, asthma that are common here, how they are responding to the vaccine, and how much is the reaction to the vaccine once they have received, and how effective it's going to be. And this, we are excited about it because we hope that we can build capacity here in Malawi of seeing this. And if the results that we're going to get from here, we hope to apply for bigger grants that can increase the capacity in Malawi in terms of the COVID studies. So we are excited about that. We are working with our colleagues from Glasgow at the Virus Center, and Paul can talk about that. So maybe for a presentation, that's about it, about Blantyre to Blantyre, and I should say thank you. But because I work with Paul, if you would allow me, if you'd want to add something else on top of what I've presented. Thank you.
Thanks very much, Mapatso. Maybe just a couple of things to add. The main thing is that it's been a great pleasure to work with yourself and colleagues in Malawi in partnership to create this. And I think it's an excellent facility, as you said, to allow accredited space. And that really has leveraged not only the funds that you talked about, but a lot of other funds to supply the equipment and the solar energy, because people have confidence that it is an accredited, internationally accredited lab, and they can do all of the work that they need with electronic financial management systems, freezer management, laboratory management systems, and so on. And all of those things have been so important, I think. And also, you mentioned the COVID work. This has also facilitated rapid movement of reagents and information between Glasgow and Malawi throughout the COVID crisis, which I think has been very important. And as you said, we'll build on this bigger study as well. So congratulations to you. You've been the main lead person on the ground in Malawi on what I think is a fantastic facility available for everybody to partner with you. So I think it's fantastic.
Professor Garside, thanks very much indeed, and Professor Mapando for that inspiring summary of the tremendous multifaceted project that's been going on between the University of Glasgow and the College of Medicine. I wonder, does anybody have any questions for Professor Mapando or indeed colleagues in Glasgow? Please just wave or unmute and speak up. We will share Professor Mapando's presentation with all participants afterwards. So I just see messages of congratulations coming in, Professor Mapando, in chat.
Chairman, I did put a question in, but I can say it if I'm allowed to.
Thanks very much. I'm sorry I missed that. Please go ahead.
My name is Dr. Shobha Srivastava. I'm a retired consultant from the National Health Service. I live in the northeast of England, not very far from yourself. And my question is that recently I read about them talking that mixing of the vaccines would help increasing the immune response in the subjects, meaning thereby that if Pfizer savers say 95%, if you mixed it with AstraZeneca, you might get 98% or so on. So is that correct? Has it been proven by anybody so far? Thank you.
So maybe as an immunologist, I can take that question, Stuart. There are indeed ongoing studies looking at the combinations of vaccines for exactly the reasons you're talking about, to enhance immunogenicity, also not only the quantity but also the breadth of the immune response. And so there are some initial studies on that, and the results from those are out, and they look quite good. And there are ongoing further clinical trials. For the studies in Malawi, initially we'll start with the vaccine that will be available to us, which we hope will be the AstraZeneca vaccine. But once we have the baseline and basically the ability to do the studies and all of the assays and everything that's set up that Mokgweetsi indicated, then we can obviously use that to roll out to check for immunogenicity for the other vaccines and combinations of vaccines as well. And not only the vaccines available in the UK, but also the vaccines available internationally via COVAX.
Well, thank you very much. Can I ask a further question, if that's okay? And that is about the booster dose. Now, I'm 87 years old, and I've got COPD, so I got my first 2 doses pretty early on. In fact, in end of 2020. So it's been 7 months now. And I was just wondering whether I did read yesterday that the boosters are going to start the same time that we get the flu jabs, which will be around September, early October. So what do you think? I had Pfizer to start with. Now, the booster, could it be any? Will it make any difference if I had one or the other?
So maybe what we could do, because we're a bit limited for time, I would be delighted if you want to email me directly, and then my email will be available and I can put you in touch. We can discuss with colleagues to make sure that you get the information that you're interested in there, because I think we're kind of a bit behind that in Malawi, but we'd be delighted to help out with those specific questions if you want to email me directly.
Okay, thank you very much. I'm just a nosy Parker. I think I read everything about everything. I've retired, so it doesn't really matter. But thank you very much. I will write to you. Thank you.
Okay.
Thanks very much. And no, the questions of interest to many of us, I'm sure. The Virtual Doctors is a UK-based charity with a Zambian operation, which uses a simple smartphone app to connect rural health centres in Zambia and parts of Malawi where there are no doctors. The charity has over 200 volunteer doctors based predominantly in the UK. Graham Precy is their chair and I think joins us today from Normandy in France. Bonjour, Graham, over to you.
Bonjour, Stuart. Can you hear me okay?
I can, thanks, and see your slides. Thanks. Please go ahead.
No worries. It's a real pleasure to say hello from Normandy in France today. So I have the pleasure of representing the Virtual Doctors CEO, Hugh Jones, who's on holiday after a very well-deserved rest after a very long year. I just wanted to give you a quick update on what we're up to. We are a UK registered charity. We also have a charity in Zambia and just establishing a charity in Malawi. What we do is very simple. Every single day we have 210, 220 doctors from the NHS in the UK, and they finish their very busy shifts and they log on to our app, the Virtual Doctors app, and they review cases that have appeared in rural clinics in Zambia that day. And those cases are typically cases that are relatively complex, sometimes emergency, but they're typically ones where the clinical officer in country in that community is struggling to work out what to do. And through our technology, we basically triage the work into 25 different medical areas. and we provide, it's a very simple app that provides photos, key pieces of data around the patient's condition, and text. And it enables the NHS professionals in the UK to review the case and to provide feedback and suggestions for improving that person's life. So at the moment, we have 200 NHS doctors connecting to 200 clinical officers in Zambia. And it impacts around 4,000 people's lives positively every single year. We've been going for 14 years. The charity started because of Hugh Jones, our founder and CEO, who was a tour guide in Zambia and came across, frankly, too many people dying of things in the back of Land Rovers where they couldn't get to a hospital where that is often taken for granted in the UK. And that's Hugh's fire in his belly, if you like, to create the charity. And he started off looking at satellite communication technology when he came back to the UK. And now we have our own bespoke app. What we do is very simple. We try and keep patients in their communities, in country, avoiding unnecessary travel, but getting some of the best knowledge in the world into the patient plans of those clinical officers in Zambia. We also try and capacity build the knowledge. So what's really important to us is, as the knowledge builds up in country on those 25 medical conditions through our app, that the triage is done in country as opposed to sent across the other side of the world. So we estimate that we export around £500,000 of medical expertise, if you paid for it privately, into Zambia every year through our volunteering work. And we're very privileged that Hugh and team have been talking to the Malawian Ministry of Health about through an MOU to expand our service into Central Province in the next 12 months, the districts, and then to all districts in Northern and Southern provinces by the end of 2024. So Zambia, we've been in for a long time. Malawi is very new to us. We've lots to learn. We're very pleased that we could have the opportunity to talk about what we're up to through this network in particular. We've got a lot to do. But we've also got a lot to get on with practically. We've secured finance to get us into the first 56 health facilities through our donor network. And as ever, we could always go a lot faster if we had other people helping us with their knowledge, their expertise, and their network. So we, as you can see from the picture, it's a very simple app. And it saves lives. People fund us through lots of different reasons. One is because they believe in health inequality needs fixing. We're increasingly seeing the frontline impacts of climate change through our service. So we are, for example, in Zambia, we are seeing a real prevalence in snake bites changing as the rainy season changes. For example, so we are seeing populations not quite tuned into some of the risks that climate change is in the way that it's really coming head to head with people's health. So yeah, we've got a lot to learn. We've got a lot to learn, and we've got I'm keen to take questions, but we are and I probably haven't done justice to Hugh, our CEO, who is very passionate and spends his working and home life trying to improve people's healthcare. But we're really pleased to be working with the Ministry of Health around their telemedicine service to show what has been done in Zambia can be done similar but differently in Malawi.
Thanks very much indeed. One of the things that has always impressed me about participants in this forum is that, to pinch one of David's phrases, people are very good at leaving egos and logos outside the door, and of showing humility. And you were saying there that you've got a lot to learn, and I'm sure a great deal to offer. And if this forum is a way in which expertise can be fed in and shared into continuing your plans in Malawi, then do please be in touch with us. I know that the Ministry of Health, with whom you're in close contact, is very well represented with us today. I wonder if anybody has any questions for Graham at this stage.
Hello, hi. My name is Charity Gladstone. I am president for Malawi and UK Nurses Association. You are doing great work with what you're doing. Yeah, I'm really so impressed. And as nurses in diaspora, or having worked in NHS for many years, and from experience, we've seen that healthcare can be episodic and fragmented. And from the examples that you cited, that you've seen maybe kids, or the experiences of kids dying at the back of ambulances or Range Rovers in Malawi or whatever. I just wanted to find out whether there's some kind of collaborative working with the nurses with your organization as well.
Yeah, absolutely. So we're very early stages. We're aware that there's different titles for different healthcare representatives. So, for example, in Zambia, we work with the clinical officers, which I believe are equivalent to nurse practitioners in the NHS. So, yeah. Absolutely. You know, our aim is to get some of the best knowledge in the world into the right place initially, and then for that knowledge to stay in country, in whoever is providing the healthcare system to improve people's lives. So, absolutely. Through our very simple app, our aim is to export knowledge quicker than it would happen naturally, and to improve people's health as a result of that. So absolutely, I'd love to talk. Absolutely.
Okay. Are you able to share your contact? Because I can only see the screen. Well, maybe it's my eyesight, but yeah, I can't.
Absolutely. I'll drop my contact details into the chat. No worries.
Thank you. Thank you so much.
No worries.
Super, Charity. Thanks very much for the question. Really useful, and Graham, for your presentation. Do please keep in touch with the forum.
No worries. Thank you.
Now to COVID-19. Firstly, we recognise the grave loss of life due to COVID in Malawi, in Scotland, and elsewhere in the world. The impact on people's physical and mental health, separation of loved ones, impact on livelihoods, and on projects between our two nations. The key topics that our members and their partners have identified as most pressing for this meeting are these: the picture today in Malawi on transmission rates, vaccines, how are stocks, how is rollout, how is the process of challenging misinformation about uptake of vaccines, and of access to oxygen. We hope to hear first from Dr. Chalamira Nkoma, who's co-chair of the Presidential Task Force on COVID-19, and then from the Secretary for Health in Malawi, Dr. Charles Mwansambo, followed by Q&A. Again, please do put questions and comments into the chat. Dr. Nkoma, thanks very much indeed for making time to join us today. May I invite you to address the meeting, please?
Good afternoon. Thank you for the invitation. Can you hear me?
Thank you. We can. You're a little faint. If you're able to come slightly closer to the microphone, that would be super, please.
Better. Hello?
Hello, yes, that's clearer. Thank you. Yes, please.
That's clearer, okay.
Yes.
I was hoping that it would actually be my colleague who had agreed with Dr. Queen Dube, the Chief of Health Services, or whether it would be Dr. Charles Mwansambo or the PS, to deal with the COVID status issues.
Very
yes,
good.
I think I'll handle the updates, and then you come in to talk about the national response plan, if that's all right.
That is correct. So maybe if
okay, good.
The organizers wouldn't mind, maybe Dr. Charles Mwansambo should start, and I'll speak to the latest national response, preparedness and response strategy and plan.
Very happy with that. Thank you. Dr. Mwansambo, you've joined us previously. Thanks very much for coming back.
Thank you. It's always a pleasure to come on this forum. And good afternoon. And As Dr. Shamila has mentioned, I will talk about the update and we'll come to talk about the national response plan. I hope you can see my presentation, can you?
Yes, thank you.
Okay, good. Just so I'll talk about the pandemic as of today. Most of you are familiar with this timeline of events. 31st of December, we are alerted of unusual cases of pneumonia in Wuhan, China. 30th of January, declared a public health emergency of international concern. In March, after WHO declared this a pandemic, Malawi declared disaster on the 20th of March, and we had our first 3 cases on the 2nd of April. We saw an increase of cases May to June. We gazetted our rules in August, and then thank God the cases started going down November, September, November, but unfortunately end of December they started going up again, and this is our second wave. And then February, March, they went down again. And unfortunately, from about May, June until now, the cases are going up again. And we are currently in our 3rd wave. As of yesterday, we registered 516 new cases. And cumulatively, we've gotten 53,503 cases. At present, we have 12,524 active cases, and in our facilities, currently admitted, we have 388. The median age of all these cases is 34, while as if you look at the deaths, the median age is about 60, and so far we've lost about 1,700. We currently are using the real-time PCR in 16 centers. We're using the GeneXpert in 39 centers and using the antigen in about 211 centers. Unfortunately, our case fatality ratio is about above the global average because it's 3.2%. Our recovery rate had gone up to the high 90s after the second wave, but now it's down to 72.5%. And mainly we're dealing with alpha, beta, and for the 3rd wave, it's mainly the Delta variant. This just shows you the weekly figures. So we had that 1st wave, 2nd wave, and a 3rd wave whose peak, we seem to have hit the peak with an eye of imagination. So if you look at the peak for that 3rd wave, is not as high as was the case in the 2nd wave. And even when you look at even if you look at the positivity rate, I think it's looking the same. And then this just shows you how our figures are comparing with the region. Just look at the shapes, don't look at the absolute numbers here, because the rate of testing is different in different countries. So you can see South Africa reached their peak, they're going down. Zimbabwe reached their peak, they're going down. Zambia too, the same. Mozambique is still its own way up, but I think with an eye of imagination, you can see that they've reached a peak. And Malawi, we may just have turned, but it's too early to celebrate. This is what I talked about earlier on the positivity rate. You can see that even during this, we'd gone up to about 35 positivity rate during the 2nd wave, but this time around, I think the highest we've done. If you look at this curve here, we seem, except for somewhere around week 29, I think most of the numbers have been below that. And this shows just the admissions and the deaths are just matching what I've already talked about. And then talking about the bed occupancy as of the 3rd of August, there are some sites. Karonga is next to the Tanzanian border. They have 8 beds. They currently have added on a number of beds, but those are not on the official number. That's why they're at 150%. Rumhi in the north as well as 100%. Chew in the center has 10 beds, but most of these have the potential to extend their capacity. The main center in Lilongwe, KCH, we We have that capacity is not reached maximum capacity as was the case during the second wave. Mzuzu is ISO2 is, if you look at Queens there, I mean, the occupancy rate is 62% and Zomba at 52%. This is looking at the number of beds available versus the cases. This just shows the oxygen supply. I know that there's going to be a whole agenda on oxygen, so I'll not do much on this, but we have a number of sites that have the oxygen plants, and we've arranged with some local providers, Afrox and Industrial Oxygen. We bought the liters well in advance, thanks to the Global Fund. So the districts are just going to withdraw their supplies of oxygen. Health workers are a marker of how bad the infection is in our facilities and in the country. So far, about 2,038 have been infected, 57 in the last week, and 1,931 have recovered. Unfortunately, we lost 24, and all the districts have been affected. Most of the people affected are the nurses and clinical officers, according to that pie chart there. And the health workers are mainly in the urban areas. And Zimba North is where Mzuzu in the north is. There's Lilongwe there and also Blantyre. On the COVID-19 updates, according to the Malawi, in fact, previously our only recommended a vaccine was the AstraZeneca one, mainly because of issues around efficacy and storage. Because our EPI program uses a cold chain which ranges from 2 to 8 degrees, and we couldn't go for Pfizer with a -80 ultra cold chain, and so to Moderna. And at that time, J&J was not yet on the market, but recently we gotten a recommendation from the MITAG to add on other vaccines to our platform in addition to AstraZeneca. So now we can use J&J, Pfizer, Moderna, Sinopharm, Sinovac, Sputnik, and Moderna. Pfizer has been added here because of the recent developments where you can take it out of the -70 and put it at 2 to 8, and it can last as good as it can last up to 31 days. So that being the case, now we're able to include Pfizer on the program. So far, Malawi is planning to immunize 60% of the population, which is about 18.8 million people. So at present, we're immunizing anybody above the age of, sorry, that's the total population, 18 million, but we're planning to immunize everybody above the age of 18, which makes the total at 11 million. So far, the dose we've used mostly has been AstraZeneca. We have taken 12 weeks as the interval between the two doses. So far, we've received 704,000 doses. And these came from COVAX, 360,000 doses. 102, we received that as a donation from the French through the COVAX facility. We had a donation of 102 from the AU. And this is the consignment, which only had a 2-week span, expired on us. We used most of it, and except for about just under 20% of the doses. This was about 19,610 doses. And we also had another donation from India of 50,000. We are expecting more doses. This time, we're getting the J&J coming this Friday, and we're getting 302,400 doses of that. And within this third quarter, we're also getting Pfizer, 372 doses. And from AstraZeneca, we're getting an extra 300, from the COVAX facility, we're getting an extra 360,000 doses. And government, through what is called Africa Vaccine Acquisition Task Force, we are procuring 1.860 thousand doses of the J&J. This is through the Africa Union, CDC, and the Afreximbank. So within this quarter, we're expecting about 1.3 million doses, and the 1.8 we're looking at the fourth quarter of the year starting October. So this is the categories that have received the jab so far. We've gotten to over 70-75% of the healthcare workers, but we've also included other social workers, and they are just the various age groups that have been vaccinated. There are a number of public measures that we put in place. We didn't go for universal testing. We're focusing on the symptomatics, those coming in, those the high-risk groups and outgoing travelers. That's why when I was presenting the graphs, that I was talking about looking at the shapes as opposed to the numbers. So for tracing, we're identifying and following up the contacts. At present, we are quarantining the confirmed cases, but also we are quarantining those that are coming from high-risk countries. So we haven't downgraded them yet. So India, Pakistan, Nepal, and Bangladesh and Brazil are still on our high-risk countries. You'll be pleased to hear that UK was never there. So for now, at least for now. So on the healthcare settings, there's a mandatory masking, and we making available PPEs for healthcare workers. And I've already talked about the measures for travelers. We are insisting on 72-hour negative valid certificate before you come into Malawi. And we're carrying on with a lot of risk communication and also enforcement of the public health measures. And at present is the vaccination campaign ongoing, and I'm pleased to report that the response has been good. I mean, initially there was a lot of hesitancy, but now we're overwhelmed. I mean, the 192 doses that we got last weekend have barely lasted a week. So people are coming, and there are long queues coming for the vaccine. Areas needing support, well, at present, we have to send our samples to South Africa for genomic sequencing. So that's one area that we need to support our local team here. The College of Medicine through MLW are actually doing some sequencing, but we want to reinforce the samples that we test per week, and so 2 per month. I did talk about oxygen. I know that there's already going to be talk about oxygen here, so I'll not do much on that. Now that we bring the Pfizer, we need an ultra cold chain system support. I mean, we're working on that, but we'll value any extra support on that. Data is quite critical. So, most of it, we want it real time because people are eager for these numbers. So on a daily basis, we have to release, but at times when there's delays because of the capacity at subnational levels. And of course, we have to ensure that there's PPEs around, diagnostic stocks, and oxygen-related supplies. And at present, I think the bill is at about 400 million for the 12 months. I'll stop there for now, and thank you very much for your attention. Maybe at this point, I can hand you over to Dr. Chalamila Nkoma to take us through the next part, unless you want to pause here for Q&A. Thank you very much.
Thanks very much indeed, Dr. Mwansambo. No, very, very happy to carry on with the co-chair of the Presidential Task Force. Dr. Nkoma, over to you. Thank you.
Thank you. I will try and share my my slides. I have a few slides. I hope you can see my slides.
Yes, thank you.
I will just build on what Dr. Mwansambo has said. The progression of the epidemic in the country has shown what has worked, what has not worked, what remains as a challenge to be dealt with. And we did see when he shared the comparison of countries in terms of the waves, the first, the second, and the third wave. And that's mirrored more or less the same way that the African region is also reporting. Indeed, we are all crossing our fingers, hoping that the Malawi curve is probably stabilized and beginning to drop now. Still, we have noted that we are not the only ones who have this epidemic, and the threat that is with us can originate from within, but it can also originate from without. And the without is on the right side of my slide, where we are seeing the trend in different regions of WHO in this case, which does indicate, as Dr. Mwansambo mentioned, that we have to consider certain regions, certain countries as high-risk countries. And the problem is that, of course, these rises and waves do not occur at the same time, which means that we must be alert and able to deal with them when they occur, irrespective of where they have come from. So having implemented 2 response plans, the first one was a short one, soon after just as the first wave was beginning, and the next one was implemented and it ended in December of last year. We have used the time in between until the beginning of this July to come up with a new plan and more or less include some aspects of a strategic approach with developing those plans. These are the oversights of that particular document, which just got released and it's available now. First of all, we think that having learned a few lessons, what we need to continue to do is to implement strategies that will help to interrupt transmission of the virus, but also to reduce the burden of disease and death among those that have been or have been seen as the ones suffering the most. Clearly, this is for everyone. So that probably remains the main medical intervention that we must continue to focus on. But the other one is not to forget that over and above the COVID epidemic, there are also other health services. And so the health sector will need to make sure that while we are dealing with COVID as an emergency, as a disaster, we should not ignore. Therefore, we must provide for the other services which are equally essential. We have seen that while this was a biological pandemic disaster, it has resulted also in other after effects, and economic impacts, social impacts have been some of the major ones, affecting some populations, vulnerable, particularly the peri-urban, but this last wave has shown us that even in rural areas, the impact is also felt. Finally, as Dr. Mwansambo mentioned, we think that we need to be keeping our tabs on what is happening with the virus in the country, which ones are coming in, what is the evolution of them, and therefore we must support not only innovations, particularly in diagnostics, including building a network of diagnostics that is going to allow us to characterize the virus that is circulating at any point in time, but also to embrace research on diagnosis, on disease, on modes of treatment and care, but also on the impact of interventions that are being provided. We believe that in order to do justice, we must target several levels: the community level, at the points of entry, at health facility levels, at infectious disease treatment centers. Now, these two the distinction between the third and the fourth recognizes the role that mainly the central hospitals are playing in managing the more severe cases. But the last one is equally important, which are the non-medical levels. We must make sure there are legal frameworks that are going to support what it is that is being promoted. The education sector has had to deal with cases at schools, in teachers, in students, particularly when it comes also to issues of social distancing, as well as the provision of preventive measures in schools. And as I mentioned earlier, social cultural issues and impacts which the epidemic has brought about. These are the 5 levels that we have decided we must have. In doing it, we have agreed that there must be some underlying principles. The first one is, in order to be able to hold everybody accountable, there must be one coordinating authority, which is supra-ministerial. And indeed, the Presidential Task Force does work with the Department of Disaster Affairs in making sure that this is being achieved. The second one is to make sure that there is harmonization and alignment, particularly with the Malawi 2060 vision, so that whatever activities are being planned by all the clusters that have been given the mandate to deal with issues in that cluster must be aligned to what this particular vision is expecting. Issues of subsidiarity. We have discovered that we need to decentralize these services further into the periphery. It's not possible for us to continue to deal with everything at central. Then solidarity towards universal coverage, to make sure that this is a human right, but also cost efficiency by choosing those interventions that are going to give us the most results. But finally, and it's not because it's the least important, it's the technical and financial accountability. Technical in terms of making sure we are doing audits of what it is we are doing and assessing the effectiveness of this intervention, but also accountability for the financial and material resources that are being provided. Again, this must be done by a supra-national, supra-ministerial body. So we have a few objectives that have been specified for the short term and for the long term, and I'll briefly say a few of them. Increasing and strengthening public knowledge, awareness, and behavior. We have known it, we have noticed that during the last 2 waves, there were definitely a lot of misinformation. There were also some myths. There is also lack of information, particularly at the peripheral level in the rural areas, about the virus itself, about the interventions, and lately, even the vaccine. We also think that we should strengthen the core capacity of the country to detect, as I mentioned earlier, the diagnostic capacity must be strengthened to the extent that Dr. Mansamba was talking about. We should be able to sequence which particular variants we have at any point in time. And we should decentralize those services to the rural areas. In a number of districts right now, specimens were being collected and sent to the central unit or at the district headquarters, and the results will take much longer. That has also affected our points of entry, where people would go and collect specimens, but they would not do the testing on site. We think that this is something we need to deal with and make sure that testing is available at the points of entry, immediate results, so they can take a decision right there, but also within the districts, decentralization to the far to reach areas, at least with the rapid test to begin with. Confirmatory test can be sought from the central district. Then the surveillance issues, including accounting for occurrences in rural areas where we are not having solid recording and reporting systems. We have learned, for example, from rural areas and leaders, that a lot of deaths this time around in this particular phase have occurred in the rural areas, but we don't have a record. So it will be important to try and capture some of that information. As we develop the recording and reporting system, we think that we must diversify and go beyond the key performance indicators that are being collected now for all other diseases of infectious disease interest, but in particular, also the deaths that are occurring, including verbal autopsies where possible. Then, of course, the coordination issues at different levels. We do have a system for implementation and responding, which has used a cluster system. The cluster system was trying to make sure that every sector is going to be part of it. And that does include the ministries, that include the councils. And we believe that this coordination needs to be needs to be strengthened. Two others, which are long to medium term, readiness for not disrupting the essential health services. I did mention this before. And we think that this is critical. We have learned, even during the Ebola experiences in the African region, that when you are responding to the Ebola epidemic, you could forget all the other diseases. And indeed, now we have seen already mother-to-child transmission issues, HIV, TB, malaria, non-communicable diseases. All these require attention, and they should also be provided for. Then, of course, finally, strengthening the conduct of basic research, as I mentioned. Some specific areas for that, and I'm glad Dr. Mansamba has already highlighted the characterization of the virus, the modes of transmission, the clinical course and severity. How about outcomes related to the modes of care, effectiveness of those models of care and modalities. But also we haven't started looking at the secular, long-term security and immunity. How long does it last? How long do people continue to suffer even after they have recovered and declared negative? And not least, cost effectiveness of the intervention. We therefore have come up with about 14 areas in that document, which are going to be focused on programming, management and coordination, risk, communication and engagement of the communities, surveillance, management of management of points of entry, the laboratory diagnostic system, as I mentioned earlier, infection control, case management. And if I can say something about the case management, we believe that one item we must embrace is to make sure that there is enough isolation capacity at the central hospital for the more severe cases, to the extent possible, even having specific infectious disease units that are big enough to accommodate up to, at the central hospitals, at least 200 beds plus. And then a minimum number of cases of beds, isolation beds at the district hospital. Again, something like 30, 40, because we have seen that some of the districts have actually had need this kind of capacity. Operational and logistical support must be there. Vaccines and vaccination, and again, a little something about vaccines and vaccination. We have heard from Dr. Mansambo that we would like to vaccinate 11 million people as first target, because we would like to get herd immunity. To do that, we need to do it as fast as possible and not take too long. Therefore, while we are procuring vaccines and getting some through the donations or the COVAX facility, we definitely would continue to need support in this particular area for more vaccines and for more logistical support to deliver those vaccines in the shortest time possible. As indicated by Dr. Mansambo, it's a mixed method approach. We may have to do targeted campaigns in some cases, I think, in order to be able to do this in a shorter time. The education sector is the critical area. Social protection and support. This one suffered a lot. The only response that has been done so far was in 4 cities and in a few 199,000 households. They were given some cash transfers, but this was not adequate. There were many more that would have benefited. We will continue to have this evolving and developing even more. Enforcement and security for the police and the other armed forces. And as I said, research and innovation. The budget that has been put together based on what the clusters were asked to calculate is a total budget of 358 billion US dollars. And what is available at the moment, from what we can count, is about $81 billion, meaning that we still have a shortfall for implementing this 1-year-long plan of 276 billion US dollars. And the breakdown by cluster in that slide. I have already made available these slides to the organizers, and I think we are happy to share them. I think this is my last slide. Thank you.
Thanks very much indeed, Dr. Nkoma, for a very comprehensive sharing of the new plan and the update. Dr. Mwansambo of how things are in Malawi. We've a question from Willan Kalinda in Mzuzu, which Willan's invited me to paraphrase. And that is, how prepared is the government in Malawi to ensure that the vaccine reaches rural areas? Secondly, there seem to have been quite a lot of side effects for people following the second dose of vaccines. And thirdly, Willan suggests that there's a need for medical professionals to come to rural areas and make the case for vaccination. I wonder who would Dr. Nkoma, would you like to respond to that?
Thank you. For the how ready is the ministry to provide the vaccines? I think Dr. Mwansambo would have been best placed, but I think I can speak on it. And
yeah, go ahead.
The initial supply that came in the country, as mentioned earlier, was met with quite a bit of hesitancy from all corners, including from urban areas. But after the second wave of the epidemic, our experience and information, and we have been, I think, proved right by the occurrences in the third wave and the third supply that we received, the second supply of vaccine that we received. The mood has changed. People are now looking forward to it. And what we found very pleasing recently is that when the vaccines came, the 192,000 doses, they came on a Friday. They came on a Saturday. And by Monday, the Minister of Health had distributed these vaccines definitely to the entire country. You would go to any little health center and you would find that the vaccine had already been delivered. As a task force, we took it upon ourselves as soon as the vaccines were distributed, went out and distributed ourselves to the entire country by region. By fourth day after the delivery of those vaccines, there was not a single vial left. And this was happening not only in the center, in the town centers or city centers, but even out there in the very peripheral. Yes, the amount was not enough. That's the only issue. But if we can go by this experience of how well the distribution was done, I think Malawi has a system that will be able to distribute more vaccines. All we have to do is to gear ourselves up with the logistics support to deliver more doses in a timely manner. But I think the capacity to do so in terms of system is there. If you talk about the side effects, I think it is pleasing to know that actually the EPI already has a system for tracking side effects, not just for the COVID vaccine, but also for other vaccines that have been given in the country. It is the analysis of that information eventually that is going to give us some insight to how big was the problem. Clearly, people would talk about side effects, but we don't know the magnitude of that side effect and the severity of them. While it is true that vaccines always give a bit of side effects after the few days after you receive it, it doesn't matter which one it is. I don't think we have solid evidence at the moment for anyone to say comparatively that the second dose had more side effects than any other dose. I think we should wait for the analysis of the information. Then I think we can be able to make a statement. But yes, the EPI has a system, the WHO, the Minister of Health has a system. It is collecting this information, and we hope that it will be enough at some point for us to be able to interpret it. But I'd like Dr. Mwansambo.
Thank you very much for that. In fact, there's the adverse events following immunization team that meets regularly, and we haven't had any major side effects that warrant concern. And I think to say the second dose had more side effects is more of perception as opposed to fact. So, but we're closely monitoring the adverse events for immunization, both actively and passively. There's a question on e-platform for vaccinations. In fact, we report to the WHO, who then put it on the global platform, so you can see the actual numbers of vaccines we received, the people who immunized, and how many vaccines are remaining in the country. And we're in the process of developing an electronic digital certificate, which people will be generating themselves if they go to our website. So that's already in place at present. Thank you.
Thank you very much. And a question there from Neil McComasty on how the 11 million target population will be prioritised in terms of the vaccines that you mentioned were going to be available. I think 60% of the population you said was what was anticipated. So how will that very difficult task of prioritisation be done?
In fact, it's already done, because we have a national vaccine deployment plan. So the 20% support we're getting from COVAX is targeting healthcare workers, those above the age of 60, and those with comorbid conditions. Yeah, we're talking about those with high blood pressure, diabetes, hearts, and so on and so forth. And then the moving up will then go according to the need. But at present, the priority is at 20%. And as you may have heard from the presentation, we opened it up quite early than many countries. At the time when the UK was hesitant about immunizing those below the age of 30, we'd already started immunizing anybody above the age of 18. And one of the major drivers was that we had this consignment of 102,000 doses that only had 2 weeks before expiry date. So if we restricted it to the high risk categories, then a lot more would have expired on us. That's why we made that conscious decision to widen the grouping. And indeed it helped in that we only lost 19,000 out of 102,000 doses that we received. So yeah, there is a plan, and I think the National Vaccine Deployment Plan is no secret document. It can be shared if members want to have a copy of it. Thank you.
Thanks very much indeed, Dr. Mwansambo and Dr. Nkoma. You're both a huge job and extremely busy, so we very much appreciate you taking time to share the new plan and the update with us. Thank you so much. You're very welcome to remain with us, but we appreciate if you need to go and deal with other pressing duties. Thank you both.
Thank you. It was a pleasure. I will ask to leave.
Thank you so much.
Thank you.
Take care.
Thank you very much. Thank you. I'll stay on for a few more minutes, and then yeah, sure. This is equally pressing, by the way.
Thanks so much. Well,
Thank you.
To hear more on oxygen, we're joined by Surgeon Mr. Alberto Gregory, who's the chair of the Scotland-Malawi Oxygen Supply Coordination Group. Mr. Gregory, you're joining us, increasing our European credentials further. You're joining us from Croatia today, I think.
That's correct. Thank you very much for asking me to talk. I'm quarantining in Croatia because it's much nicer than being in a hotel in Heathrow Airport. Can you hear me all right? Yeah?
Yes, thank you.
Okay. So I was very privileged to be asked by David Hope-Jones to chair the Scottish-Malawi Partnership Oxygen Appeal and to have an idea as to what to do with what appeal funds we were going to get and to try and prioritise. And you've heard from Charles and Sambo about a lot of work's been done by the Minister of Health, the task forces, both the COVID-19 task force set up by the President, but also by the Minister of Health Oxygen Task Force to try and identify what could be done quickly. So we're able to launch an appeal on the 16th of February, and 2 weeks later, when the appeal closed, we had been privileged by having over £40,000 donated by the Scottish public and other charitable organisations. Very quickly, we put together a group of people that were interested and had knowledge, both technical knowledge from a medical point of view, but also country knowledge, to try and work out what was the best thing to do. Because clearly the needs for a small NGO such as Scottish Malawi Partnership and what we could do in terms of quick deployment, get the best bang for the donated pound, had to be balanced against avoiding duplication, because obviously the ministry was working with major donors to try and get the major oxygen sources developed and deployed as well. The goals obviously had to be realistic. It's very nice to have the WHO lists and say this is what we'd like, but could these be delivered in time? And all this has to be against the background, as you've heard from the previous two speakers, Dr. Nkoma and Sambo, is we need to look at the long-term benefit for Malawian healthcare. So very, very quickly, because we do work in Malawi, we've got first-hand experience, the first actions we realized was that you need to measure the oxygen saturation of patients that have COVID. It's part of the diagnostic pathway, but you also need to know what effect the oxygen you're giving to them is having and be able to titrate the oxygen levels that you're administering to the effect it has on the patient. So you're not overdosing on oxygen and wasting a precious resource. It became very rapidly clear from our knowledge on the ground that there's a lack of sufficient oxygen saturation monitors. And we're able to very, very rapidly source and send out the 50 saturation monitors. And we had to work out how to deliver them on the ground, because everybody was really struggling to deliver anything on the ground. And that was from the ministry, from PAMS, from central stores, because demand was just so high. So what we did in the initial bit was we actually sat down and worked out our links in the ground in the northern region, which is the furthest away from central stores and from the south and the resources, was to deliver the saturation monitors through our links in the ground and give them to the people that were going to be using them daily in assessment and treatment of COVID patients. So this was mainly anaesthetic clinical officers who were being deployed on a weekly rotation to work in the different emergency treatment units, and also to the emergency treatment units to allow them to give the right dosage of oxygen to the right patients. And these were actually very, very quickly obtained and distributed and air freighted. You see the air freight parcel on the left there by our colleagues, Medicaid International, and they're distributed by some of our colleagues, Dr. Judith Miquela and Francis Masu, who's an anaesthetic clinical officer based in Zuzu, throughout the northern region. The other thing that became very, very apparent very quickly, and we'd had highlighted this in some work for the Scottish Government last year, 2 years ago in fact, was that there's lots of oxygen concentrators in the country that are broken and haven't been maintained and could be repaired and returned to function. And we knew this, but our partners Open02, which is a charity set up by the Global Health Information Institute in Lilongwe, was that they could be repaired if you had the right materials and right equipment and the right knowledge. But the spare parts were a big, big issue, as highlighted by our PAMS colleagues. So what we were able to do was give a quick grant to Open02 to actually start going out to the community and repairing these in the different district and central hospitals. And they started doing that very, very early on. In the middle of February, we were able to give the first grant to allow them to travel down to Zomba. They'd been working on the ground in Lilongwe, and we continued that support, as I'll explain in a minute. Obviously, as again, Dr. Mansambo talked about, the information sharing with the Oxygen Task Force and the COVID-19 Task Force allowed us to know whether there's issues on the ground. And again, our colleagues and contacts on the ground were highlighting what the issues were. So basically, 3 weeks into the appeal, this is the first oxygen saturation monitor being used in the COVID ETU in the north in the Zuzu. Open02, we're checking also those oxygen concentration units, the these standalone electrical pumps basically produce oxygen. We were able to check whether they were working and whether they needed repair. And they did this using a mobile workshop that was quickly set up and developed for this purpose. It became clear as we started sending some of this equipment into the northern region, the central region, that other things were missing. And part of it was basically just exactly as in the health service in the UK. People were being deployed to doing things they weren't used to. So they weren't aware, for example, that the bullnose regulators had to be taken off the cylinders before they're sent to be refilled. And obviously, if they fall over, they get damaged. And this caused a problem. There were certain units, for example, had 4 oxygen cylinders, but only 1 bullnose regulator. So again, we're able to quickly purchase ex-military brand new MOD stock in the UK and send these out with another 37 saturation monitors to be deployed into the central region and the northern region to help people use the oxygen that was becoming available in cylinders. The other thing we became aware of was that zeolite, which is an essential part, a chemical that's an essential part of using oxygen concentrators, was in short supply. And again, very, very thankful to Alan and David for rapidly releasing just over £4,500 to buy 300 kilos of zeolite, which was rapidly shipped from China by air freight, and again was able to be used to repair oxygen concentrators. There's a fuller report that will be available on the website, the SMP website, which goes through the exact costs and timings. But basically, OpenO2 have returned to service over $500,000 worth of oxygen concentrators. And this is in a very rapid time frame, remembering that oxygen concentrators were taking 12 to 14 weeks to arrive in the country from India and China. We never thought there'd be a third wave. And sadly, I suspect there's going to be subsequent waves. And as Dr. Monsambo said, one of the things that needs to be done is to sit down and look at having a more sustainable infrastructure. And OpenO2, who've been working with the ETU and Kamuzu Central Hospital, have actually sat down and worked out a way of maximizing oxygen capacity in the ETU. And part of this will involve setting up basically a piped oxygen system fed by 2 sources, both oxygen cylinders and a bank of oxygen concentrators, and allow efficiency in terms of dispensing oxygen as needed to the patients in the ETU. And this will cost about £2,000, mainly for expensive copper tubing. As part of this, I have to say thank you to those people that have helped, both on the ground in Malawi, Judith Miquela and Francis Masu and others working in the Ministry of Health, Trisha Rao and others in the COVID task force. And this chap here and Timothy Tonga, this is Jerry Douglas from the GCCI and Timothy Tonga, who have made it possible to channel these funds very, very quickly. However, my thoughts are, I've just come back from Malawi, it isn't over. You realize how important it is to think of as a global village. We are one global village, all interconnected. And what happens in Africa will happen to us as well. We need to be working cooperatively. And as the Lancet report so eloquently said, oxygen is an essential drug and a basic human right. And it behoves us all to try and make it available to all. Thank you very much indeed.
Thanks very much indeed, Mr. Gregory, for that explanation of a really comprehensive and integrated project with great success. And on your final point, as President Chikwera said the other day in the meeting with the All-Party Parliamentary Group and members of the cross-party group, if few of us are not safe, then none of us are safe. And we do indeed live in a global village. Super, thanks so much. Well, we've heard in previous meetings about the important COVID work that faith groups are doing. SNP member Eve Hartswood contacted us about a collaborative intervention in which she's involved. And Leonda Rabbi Gareta Mazingani is with us today to tell us more. You're very welcome.
Thank you very much. Yes, my name is, the correct spelling is Lindilabi Gareta Mazinyane. I am a social worker by profession, and today I am in my capacity as a research fellow, an assistant researcher for the Faith Partners Research. And just to say a little bit more about that, this is a response to COVID-19 through the local to local church partnerships. And the local that we're referring to here is in Malawi, we have different churches. And here we're talking about the Presbyterian Church. And in the southern region, we have what is called the Blantyre Synod. So there is a local church within the Blantyre Synod, which is in the southern region of Malawi, and it has partnered with the Church of Scotland in the UK. And in this pilot project, we are looking at the impact or the contribution that the church can make through partnerships. And this is between Malawi and Scotland. And many people have already said, can you compare Malawi and Scotland? It's like you're comparing oranges and bananas. But yes, there's so many areas whereby we can compare Malawi and Scotland. I'm going to talk through about what we've been doing, but just to say a little bit more of who is in this study, we have the Church of Scotland, the Faith Impact Forum, and the University of Edinburgh, which is also having the global health. And the University of Edinburgh, the Department of Divinity is also in this study. Locally in Malawi, we have the University of Malawi who is hosting, and there we have a lecturer who is Reverend Dr. Chipa, but also within the Blantyre Synod, we have Reverend Thomas Nyangama, who is a PhD student. We have the Starfish, which is an organization in Salima, which is also doing great work in COVID-19 information dissemination with the local communities. And of course, the Scotland-Malawi partnership and the Scottish government, especially looking at the issues of vaccination. So here in the research that we're conducting at the moment, we have 100 questionnaires whereby we have selected a small community in the southern region. And within that, we are asking the important question, which is asked in both countries for Malawians, but also for the members of church in the Church of Scotland, to say how have they learned about COVID-19. So issues of prevention, issues of transmission, and it has been quite interesting in terms of the responses. And what is coming out quite strong is that the radio at the moment is very vital in terms of sharing information. So in the local context here in Malawi, many people are getting information through the various radio stations, but also in Scotland, you have people getting information from the internet and other online platforms. And we are also looking further to the issues of vaccination. So at the moment, it is really good that I'm presenting last after many other presentations that have talked about how key the local community is and how transmission is at community level at the moment. And what our study is doing is to see how can we bring vaccination to the local communities. And because of literacy levels, and that there are a lot of myths and misconceptions, and people may take advantage of people in the rural communities to discourage them from getting vaccinations. But through this study, we are seeing that there is a higher opportunity that we as a faith community can use the church, and we can use faith, we can use church facilities like the church buildings to have pop-up centers whereby we could pitch up an awareness meeting, and the church can also give information through community awareness programs. And through that, we can register the exact number of people who are willing to take vaccinations on a particular day. And through that, we hope that it would be possible to have the exact number of vaccinations taken to a particular rural community and given out. But this cannot be done by us as church alone. We would need the push of the government, we would need the push of the medical services in Malawi to help us to get a buy-in of this proposal that we are putting through. But yes, faith works, faith community works, and faith partnerships works. And we just want to encourage more conversation, and that we can use a platform like the Malawi-Scotland partnership as a platform to lobby for vaccination to the local community members. So thank you very much for your attention, and if there are any questions, they are welcome. Thank you.
Mrs. Greta Mazangani, thank you very much for that really encouraging presentation about the importance of faith groups' work, and as you say, the importance of key local community level actors. So thank you so much for that. We are running slightly behind in time, but I do think it important to have a chance to cover some of the questions when speakers are still with us where possible. But also the beauty of the chat function is that we do send that to speakers too, and where they're willing, we receive answers back from them to questions, and then we'll include that in what we send out to all participants. Dr. Nkoma, Dr. Mwansambo, I wonder if you're still with us for Innocent Kalieti's question on recently gazetted rules. He says he sees that we're on level 3, alert level, which does not provide for border airport closures, rather 14 days quarantine. Will we begin to see alignment between the Gazette and the situation on the ground? Will borders and airports reopen?
Yes, apologies, I missed the first part of the question.
Not at all. It was with recently gazetted rules. Innocent observes that Malawi is on level 3 alert level, which does not provide for border or airport closures, but just quarantine for 14 days. And so is asking, will Malawi see alignment between the Gazette and the situation on the ground?
In fact, currently, ideally, we're supposed to be, if you look at the scores that we follow, we're supposed to be level 5. Because you look at the positivity rate, you look at the bed occupancy versus the oxygen availability, you also look at a number of issues, and you come up with the score. So when we're moving to level 3, our score was at 17, but when we last did the calculation, it was at 25. And at the last meeting of the Presidential Task Force, they looked at the curve and the way it was going. So they said, should we move on to level 5 now and more like stopping all activity? So the compromise was we stick to the measures that were in place and monitor it for the next 2 weeks and see which way that trend will go. So it's actually a mixture of things. That's why maybe you may notice that discrepancy, but otherwise, if we're still speaking, we should have closed everything else and stayed put just for now. That's why there's that anomaly. We did seek the legal opinion on the same, and we're told we're fine. Let's keep it at 3, but make sure that some of the measures do not get relaxed yet. And there was also talk of downgrading those countries that have now worked so hard to reduce the pandemic. Here we're talking about countries like India, Pakistan, Nepal, and them. Because if you look at their positivity rate and the number of new cases there, it's gone down significantly. But those two were still kept on the red list while waiting for this this major decision. I hope I've addressed that. Thank you.
Thank you so much.
May I add, I'm also still here that
Oh, I see. Okay, okay.
closure of borders and airports is probably an over interpretation. The borders are open, the airports are open, but yes, restrictions have been made to only require essential travel. Also require from those coming in, including returning citizens, COVID certificate that is based and not older than 72 hours. And the ones that are being asked to remain in quarantine for the 14 days are only those that are coming from the specified high-risk countries. The rest of the description and the thinking behind the decisions is what Dr. Masambo has just explained. But I thought I should clarify that the airports are not closed. The borders are not closed.
Thank you very much for that. There's quite a lot of chat in chat, understandably, about oxygen, and Susan Flynn had made some points about hospitals that were waiting for repairs, and Cata Bay was one. Barry Klassen thanks Alberto, noting that the Scottish Government have recently donated funds to Kids OR charity to supply O2 equipment in Africa, including Malawi, and that Barry's made a plea to Kids OR directly to include as a priority the central hospitals in Malawi. That's Dr. Barry Klassen in NHS Tayside. So thank you very much indeed for that. And there was a question for Lindy Rabe, which is, our pop-up centres only happening in south near Blantyre? Is anything similar happening in northern districts? Lindy Rabe, I wonder if you'd like to field that one.
Yes, can you hear me now?
Yes, thank you. Please go ahead.
Thank you. Yes, I responded to Johnny to say we can replicate nationwide. At the moment, this study, it's a small study. It's just a pilot stage in the southern region in a small community. But what we're asking for at this level is a buy-in. Should the government see that it is viable, it's a viable suggestion, then we could take it. The church is quite flexible. The church has been, we have a lot of structures, the youths, the women's guilds, and all the other structures within the church set up. So it is possible to replicate. Thank you. Thank you
so much. Well, my apologies for us having run over slightly in time, but I do think a great richness of content. So thank you very much indeed, everybody, for contributing. I'd like to turn to my colleague David, our Chief Executive, David Hope-Jones, to provide a summary and his sense of next steps. Please, David, over to you.
Thanks ever so much, Stuart. This is where I do the sort of Jerry Springer's final thought piece, if that cultural reference isn't too dated or inappropriate. As Stuart says, we're a little bit behind time, so I'll be brief. Just a couple of maybe takeaway thoughts from each of the speakers, and then some next steps. We of course started with our long-standing friend, Professor Mopatsa Mapando. Always inspiring to hear from him, and I suppose one of the things that really stuck out from me was what he said, that this partnership, the Blantyre partnership, has really been recognised and accredited as an exemplar of good practice between North and South. And I'm not surprised about that, because I remember, I don't know how many years ago it was, I'm sure Paul could help me, but maybe 4 years ago, sitting around in a circle in a room in the University of Glasgow, and Mopatsa was there, and Paul and Simon was there. And it was all about listening to the senior leadership of College of Medicine with an open mind and a blank page, saying what do you want and need, and the ask there was for a one-stop laboratory in Malawi. And so it's wonderful to see that physically materialize, and a wonderful example of sustainability in action, both through the sustainable energy that's being used, the Malawians, as he said, who are being trained through that process, but also the sustainability of the business plan. Thank you to Graham Tracy. The Virtual Doctors are another hugely impressive initiative. They've recently joined the Scotland-Malawi Partnership. And it's exciting that £500,000 a year of medical expertise that they've been bringing into Zambia, they're looking to do the same with Malawi. And as Stuart flagged, all credit to them, that they're going in with all self-awareness and humility and really keen to be a part of our little network and tap into expertise that's there in contact. So please do contact Graham if you want to be a part of their work with telemedicine in Malawi. It's hugely inspiring. And then on to, I suppose, the sort of meat of the meeting, COVID-19, which remains the key priority for all of us, and wonderful to listen to Dr. Charles Mwansambo once again. I think probably we're all very pleased to see that the third wave beginning to tip down, both in terms of transmission, in the number of proportion of positive results of tests, but also seemingly hospitalization as well. But I thought sobering seeing just how a higher proportion of the COVID beds, particularly in the north, are still at 100% occupancy or more. Vaccines, a clear takeaway for me, and I'm sure for you, a plan of vaccinating Malawi's 11 million over 18s, 704,000 donations so far through COVAX, AU and India. That's great, but let's not clap too loudly, given how much of a small proportion that is of the 11 million that's needed. Good news that a further 1.8 million has been ordered through the Africa Vaccination Task Force of the J&J variety. And I suppose one of the key things that I took away was when we were talking last 2 or 3 months ago, there were two parallel and equally severe issues. One was access to the vaccines, and secondly was vaccine hesitancy. And I think all of our speakers in the second half of the meeting have recognized that vaccine hesitancy issue has significantly dropped away through this third wave, which is of course good news. Dr. Chalamira and Koma, fantastic to hear about the new National Preparedness and Response Strategy and Plan, the principles on which that stands, and the short, medium and long-term strategic objectives. Perhaps the takeaway, sobering takeaway we can register is that requires Malawi to have $361 million, and so far $276 million is still remaining. The need is great, and I think it's important that we hear that the challenge is not over. And all credit to the leaders we've heard from today, who have articulated so clearly and so persuasively the assistance that is further required. It's always a delight to hear my friend Alberto, wherever he pops up. I've got to say, Alberto is far too modest to say, but he has done incredible work with the Oxygen Coordination Group. My thanks to everyone who donated to make that £40,000. But my really sincere thanks to Alberto for making that £40,000 go so very far. He said it quickly, you might have missed it, but $500,000 worth of oxygen concentrators that have been fixed, in part with that £40,000, hugely impressive. And wonderful to hear from Linda Rabi at the end there about the faith links, the impact that's having, the research and the depth of understanding that's garnering. So my thanks to all of our outstanding speakers. Next steps, I think in respect for and recognition of the value of all of our speakers, I think the first thing we want to do is make sure that their contributions are as accessible and as used as far and widely as we can. So we will get all of the presentations that you've seen today, the excellent PowerPoint presentations, and we will share those by email to you, but also on our website. If you go to our website and click past events, you'll see a dedicated web page for this event and for all events the SNP has ever hosted. You'll find the video from today and all of those documents. So please do use that resource. We will have a time-stamped video from today, so you'll be able to click a link and go straight to individual speakers. So if there's a salient detail you didn't pick up or you want to hear again, it'd be very easy to do so. With the oxygen appeal, Alberto's just emailed across a really fantastic report, as he says. We'll get that on the website in the next 24 hours and email all who donated with that powerful update. I'm really keen to say, I'll talk in a moment about next meeting, but I'm keen to emphasize between meetings, please don't wait for one of these COVID coordination meetings. This is our 14th in this series. Anything that you want to share, whether it's an appeal your organization is having on COVID or just information about what you're doing or information about what your partner needs, email myself or any of our colleagues, and we will find ways of communicating that, whether it's through social media, our website, the weekly bulletin, having an event, or all of those things. So please keep in contact. Sharing and listening are absolutely key to coordination of effort, which is why we get out of bed. On donations, it's been recognised already, Scottish Government very kind donation through Kids Operating Room, and that will buy many more oxygen concentrators in Malawi, which we welcome. Please do continue to donate to the appeals that are there, and if you have an appeal, please do continue to tell the Scotland-Malawi Partnership, and we will promote that. Vaccines, I mean, as I said, great news that vaccine supply has increased a bit, and fantastic news that hesitancy has decreased. However, as many of you will have seen, the president of Malawi was in London last week. I had the privilege of meeting him at the All-Party Parliamentary Group and taking part in the Chatham House event. And in both of those and in his interview with the BBC, the president was quite frank about the fact that there is not currently an equitable global distribution of vaccines. He was quite clear that more needs to be done. And I think as friends and partners of Malawi, we have a duty to listen to the president, to listen to the experts on today's meeting, and to use our voice to communicate our desire in Scotland, across the UK, wherever you are, for our political leaders to do more to make vaccines available in Malawi. Finally, next meeting, as I said, this is the 14th in this series. What we do behind the scenes is we're in constant contact with our friends and partners in Malawi. We're constantly looking at the news, and we try and gauge frequency of these meetings based on how useful we think they will be and how dynamic the situation. So I'm not going to at the moment say exactly when the next meeting is going to be, probably in 2 to 3 months or so. But we will email you to let you know. But in the meantime, please do keep in touch with us, keep sharing, and keep using us as your network to be able to support coordination of effort in the COVID response between our two countries. Craig, could you press the magic button and get the poll to pop up on the screen just while I finish up? Just 2 quick questions there. That's quantitative information. Great to have your feedback there. That's really useful. But also in the chat box, please do put in the chat box if there's something else you want the Scotland-Malawi Partnership to do. You can put it in the chat box now as we close up. You can send an email to me or any of the colleagues on the meeting today. I think, Stuart, that's everything I wanted to say. Back to you, and thanks once again to you, Stuart, and all of our speakers.
Thanks, David. Great. A brief mention of SNP member M's Internationals event, which we're delighted to be supporting and to which everybody is welcome. It's free, it's online, it's on the 2nd of September. Details on the screen at the moment, thanks to my colleague Craig, and more details also on both organisations' websites, ours and M's. Thanks to my colleague Craig Docking for hosting the Zoom Tech today and for catching many a curved ball as he does. To David Hope-Jones for his action-driven summaries and overall leadership. To Jade for her promotion, social media and web work. And to MASP colleagues for all of their support, their dissemination and their insight. And especially to all of our speakers for giving up time, and for you for contributing and joining us today to help contribute to this coordinated approach between our two nations. That brings to a close the formal part of this meeting. Anybody who would like to remain on Zoom for networking without Zuzu coffee, unfortunately, with one another is warmly invited to do so. But for now, take care, thank you, and goodbye.